The topic assigned to me is the panel discussion. Already my friend introduced all the learned panelists. We are going to analyze some selected cases. As all of you know that diagnosis is not the important. The point is here in the given scenario, what is our thought process? How we try to analyze and how we try to derive that what is the likely possibility and reach the diagnosis. And all of us know that I think that's the motive of keeping such type of the sessions. And I know all my four panelists, they are going to help us that what should be the thought process. I think in between, if there is some response from the audience, please raise your hand. I'm sure that I don't have only 4 panelists, but I have more than 250 panelists. And then I'm sure that we'll get the more and better solutions. With that few words, let me start the case discussion. This was a 2-month-old male child, and for your kind information, these are the all real cases which we have come across with the good records. 2-month-old child presented with mild fever, cold, rhinitis and irritability. Persistent jaundice, taking breastfeeding, non-consanguineous parents, full-term normal delivery, birth weight was 2.1, no NICU admission. Mother had fever 15 days before the delivery. This is little bit old case and therefore somebody treated an obstetrician or physician with the anti-malarials and antibiotics. She recovered. Mother had even pulmonary COX 1.5 years back. She completed her anti-tuberculosis therapy. She had one spontaneous abortion at 2 months amenorrhea. This was the information available from the mother. When I examined, weight was 2.6 kg. If I remind you at 2 months from birth weight of 2.1. Head was 34, length was 52. Mild febrile, vitals within normal limits, AF normal, PF was close. Jaundice was significant, no cyanosis. Liver was 4 cm, firm, non-tender. Spleen was 3 cm and firm. No free fluid in peritoneal cavity. Cervical and inguinal lymph nodes were palpable. Respiratory systems, no findings. There was no cardiac murmur. Neurologically, child was having the good activity. I would like to ask Dr. Any of you, yes, please. Dr. Ramesh, what will be your thought process in this type of the scenario?
Sir, can you go to first slide?
Yes, yes, sure.
Yes. So here is a 2-month-old male child, and child has come to you, sir, for mild fever, cold, rhinitis, irritability. So mostly with some intercurrent viral infection. There is a history of persistent jaundice. So baby is harboring jaundice probably since birth and has presented with some mild viral infection. Baby is taking breastfeeding, so compensated, no danger signs. Born to young, non-consanguineous parents.
I request Dr. Ramesh, because if we repeat it to take more time, already information is there. Can you focus your points and come
child
to the...
was 2.1 kg. So mother is not well, and that has reflected into SGA. There is one positive history of fever with rigors. It could be due to malaria, it could be due to UTI. It was 15 days before the delivery. So most probably that has not affected the weight. So there is something going on in mother since beginning of the conception. And sir, tuberculosis treatment completed?
Yes, yes.
Okay. So, and plus there is one spontaneous abortion, again that is not suggestive of good maternal health. Next slide please, sir. So as you said, right now it is 2.6 kg weight. So child has barely gained 500 grams of weight in 2 months. So baby is definitely having some chronic problem. And there is a jaundice. So liver is 4 centimeter from, so it is fibrous. So already it is a chronic process. And spleen is also there along with the lymph nodes. So definitely there is involvement of reticuloendothelial system in some way, and child has presented for some viral infection to you.
Uh, Sir, I would like to have a
Was
comment.
just I request to my friends that please already information is displayed. Use that information for coining some very important clues and come to the your I will say impression or the comments.
Yeah, congenital malaria would be something that I'd be looking for. I'd also looking for some congenital infections also, probably an idea from the torch
Right.
assay. And I would also like to have an opinion, have a about the eye examination. Is there any positive findings on the eye examination? I would want to look out for that. And of course, ask the mother about the staining of the diaper, the color of the stools. So that's what I.
Stool of the color was normal.
Okay. So that will then will rule out any biliary atresia or something like that.
Okay. What is your I will say ultimately focus? What do you think? As you said, one is malaria.
One is
Second, you said there's some congenital infection.
Yeah.
Okay. Anybody else? I would say
Uh,
beyond this.
yeah, a fever with lymphadenopathy always shows inflammation first.
Okay.
So there is persistent jaundice in this case. Most probably 2 months. We always have on a conventional teaching breast breast milk jaundice,
Okay.
and the condition always we are taught is UTI or malaria, where the jaundice is ongoing.
Okay.
And as the information clearly shows that there is an ongoing inflammation, probably we there is a history of tuberculosis treatment in mother, so we also have to have in mind congenital tuberculosis, and the status of mother, whether she is totally treated or not, is not known. And second thing is the posterior fontanella is closed, that means hypothyroid can be set aside here
Dr.
in this.
Rangnath, anything more from your side, or should I go further? Because already discussed that maybe the malaria, maybe the congenital infection, maybe the tuberculosis, maybe the UTI, right? I think these are the points which have been considered.
Torch
Any-
group of infections is the
Yeah,
first,
torch already discussed. Okay.
first possibility.
So I think this is the, I will say, echo of most of the friends. Let me go further.
Sir, eye examination.
More information. Sorry.
Eye examination.
Eye examination normal. Suppose if what you want, Dr. Ramesh.
Intrauterine infections to rule out.
Okay, but in the eye, what you will look for?
chorioretinitis,
Chorioretinitis, cataract.
You know that the suppose cataract, if you get that fever,
or cataract. Yeah.
Now on investigations already which we have done, hemoglobin was 9.5, count you can see normal, differential not much problem, I will say information, platelets were low, ESR and CRP not significantly raised, MP negative, as I said platelets were low, bilirubin 12, direct type 5, indirect 7, mild enzymatic reaction, PT normal, CSF already it was done because child was irritable and mild febrile, blood culture, urine culture, CSF culture, no growth. USG showed hepatosplenomegaly and of course significant cervical and inguinal lymph nodes. Now any specific points, if you make the one specific comment, I think already we have discussed from these investigations. Sir,
Yes, sir. Seeing the picture and the developments what you have presented, sir, it is an intrauterine infection that is
Okay.
going on. That is the conclusion. But if I need some more investigations, reports.
yeah, it will
to-
come, it will come. Whatever we have from that we have to discuss.
Yes.
So I think sir consider that is a likely some intrauterine infection. Okay, agreed.
One
Anything-
X-ray-
anything more?
One X-ray of long bones may be helpful.
Sorry?
X-ray of long bones.
X-ray of long bones. Which long bones?
Long bones means legs.
Okay, sir. What you want to see?
To rule out epiphysetis
Sorry?
and epiphysetis
Okay.
and periosteal reaction.
Okay. For?
Syphilis, congenital syphilis.
Okay. Absolutely. I think very important. Here, whatever the investigations were done, HbA1c was negative. Serological test for all the torch was negative. Coincidence somebody has done negative, thyroid normal, chest X-ray was normal. And already what next? Actually, we were not clear that what we should do with these investigations. But the point which I think this is also old case in the round I was there. Child was in lap of mother. For giving the findings to my resident, I touched the wrist and the child cried. I thought that the child is disturbed. But when I was palpating on liver and spleen, child was not crying. Again, for pulse, I touched, child was crying. Exactly what Dr. Rangnath has, I will say, touch. I went for the X-ray wrist. They reported osteomyelitis, but it was osteitis. Absolutely, sir, to save the time and to go for the next case, just analysis. Retrospective analysis, we came to know that there was a spontaneous abortion, which is known in syphilis. Antinatal care was not taken, and therefore VDRL was not done. It was IUGR baby. Cold, that means that was not cold, but nasal snuffle, that we realized later on. And of course, not gaining weight and jaundice and hepatocellular and lymphadenopathy. Later on, we checked even the perineal region. There was excoriation. Investigation showed anemia, low platelets, raised enzymatic reaction, jaundice. For common investigations were negative. X-ray was showing osteitis. We went straight away. Treponema peridium hemagglutination test, and sir, compliments, it was positive. Titer was very significant, gone into 320. Later on, we referred this mother to dermatologist. Mother was also positive. Child was treated for the penicillin for your kind information, and child recovered. But was the next problem, when the child was and after 2 years on follow-up, even parents were very keen. And they said that again with the report that, sir, still the TPH is positive. Low titer, but what positive? What should be done? Anybody of you, sir? Dr. Ashwant, you can take it, please. The child is treated. Child is clinically absolutely fine now. Nothing is there. Now child is 2 years old. But the parents have come with this report that still it is positive. Anybody?
I think TPHA is positive even after treatment.
Yes. So after how much time? That was the question from the parents. Anyway, anybody from audience?
I think more than 6 months.
Yeah, the point is, for your information, that the TPHA or even the FTA antibody absorption test, fluorescent antibody test, you know, the test become the positive. They say that soon even after the infection. So a newborn at any time you can go for, suppose if you are suspected, remain positive for almost a lifetime, this test. Even with this adequate treatment, it is useful for the diagnosis, but limited useful for the evaluation of response and for the follow-up. So assure the parents that the child is all right. Test is going to remain with the low titer positive, even almost maybe for the lifetime. Don't bother for that. And I think we also should not go for the retreatment or something. Thank you very much. I will say for the first case, I am also in hurry looking at Dr. Shyam Kukarija that I also want to complete the 5 cases which I have planned. So I may be in little bit hurry. I request again my friend panelists, please help me. This was a 6-month-old child, second case. Illness of 7 weeks. Fever mild to moderate, then high grade. Developed the neck swelling. Child was irritable. Hospitalized. Diagnosed with neck cellulitis. Treated with the antibiotics. You can see that almost everything was given, but no response. Meanwhile, child developed the convulsions and even the left side hemiparesis. Rest of the history was non-contributory. Anybody can give the thoughts that what thing is developing, going on? Yes, Dr. Ramesh?
Yes, sir. Looking to the history, child started from mild fever and went to severe and was treated with almost all the antibiotics. So either we are dealing with atypical bacterial infection or there is some hidden infection.
Okay.
And it has been going on since 7 weeks. So it is fairly now.
So he says either the atypical or difficult organism. Okay. Anybody is having more comments, or should I go further for more information?
So more information.
Okay, sir. I think that is a good way. And what investigations were available to me before referring this? You can see the hemoglobin was fairly good, around 8. Count was always high. Differential you can see polymorphonuclear. ESR was always high. CRP sky high. Platelets going even high. Chest X-ray, some opacity. Yes, the neck showed lymph node on both the sides. Now, sir, information is to you.
Sir, high platelet count with also a high total count also. Sir, though it doesn't fit perfectly, but two things comes to our mind. One is Kawasaki, and another is Caffey's disease. So I'll have to have a X-ray of the mandible.
Okay. Let me inform the house. The panelists, they don't know the cases. Only the clinical information. On their message, I inform that only the clinical information, important clues, and confirmatory diagnosis I have not sent to you. And that was the info. You can see that how they are able to analyze. Okay, sir, now on examination. In spite of all the antibiotics, 103 fever, mild tachycardia, tachypnea, AF was at level, pallor, eyes congested, axillary, inguinal, cervical, all lymph nodes. No murmur, irritable child. Now the child had the 7th of palsy, query, but definitely power was decreased on the left side and DTR were brisk and no next effect. I think to save the time, if I will provide you the investigations, CSF was 45 sugar, protein 120, cells only 20, MRI brain was reported as normal. Now what next?
Aseptic meningitis.
Okay, aseptic meningitis.
Fever with acute phase reactants very much increased.
Yes, sir.
With the right upper zone involvement, we can even have tuberculosis or adenovirus infection, which is very common.
Absolutely, even with the conjunctivitis which was there. Okay. Anything else, any more information, or should I proceed further? If anybody wants to add
Any
something.
ultrasound? Ultrasound findings?
Yeah, I am coming. Ultrasound of neck was done. I think already I talked to you that lymphadenopathy was there. Anybody from the house? Just comment. Non-exudative, sir. I forgot that the front rayon is filled up by the stalwart. Okay. Sir, let me go. Because you order, Dr. Sham, I can't say no. Echo was done. And that was the coronary dilatation. And even this left coronary circumference branch was also involved. And that was the case of Kawasaki with aseptic meningitis, with even the left side hemiparesis due to the vasculitis. The
Sir,
point
only-
is which we are learning from our experts, that Kawasaki probably typical now we are not missing. Almost we are fully sensitized. Sometimes on the contrary overdiagnosed. But yes, the atypical or some atypical presentation or some unusual presentation, probably that we should keep in mind. That was the point of bringing this case for the research. Yes, sir.
Sir, it is only.
Yes, sir. Absolutely. Yes, sir. Very good.
Sir,
Very
but this case, sir, your case is included in the 1 to 3% of Kawasaki's which have neurological
Yes, sir.
problems.
Yes, sir.
Yeah.
Absolutely. That was the point for big. Yeah.
Sir,
Absolutely. What sir said is that usually the typical Kawasaki present with single and even the unilateral cervical. But here we can see probably it was confusing or misguiding
both
to us
sides also, yeah.
that even the multiple
Sir,
cervical.
I would have liked another investigation, that is NT-proBNP.
Right.
Though it is not a standalone test, but still
Absolutely.
the studies that have come in, we can go for that and probably say about the treatment, because it is an indicator of whether I'll be giving immunoglobulin to that.
I will say the treatment part follow-up I have deleted for the sake of to save
Sir,
the
in
time.
most of the places we don't have echo support.
Absolutely.
So NT-probe will help you. High NT-probe will give us a 100% suspicion of Kawasaki.
Very important message, yes, sir. When, on the contrary, we are expecting that the echo should be normal and we should be get the opportunity to treat before the development of the complication. It's a good time. And for that, still we want to confirm the diagnosis. Then I think this investigation will be quite useful. In this patient there was. Yeah,
because the age is less.
Yeah. And to be very frank, because it was totally unusual, that was the point for bringing the case over here for the discussion. Or even if we give the follow-up, the child ultimately after the treatment responded on follow-up, you are totally normal. Uh, Third case, I think little bit long, so please be with me. 7 years male, illness of 20 days. I will not read all the sentences. You can see the fever, mild to moderate. Then treated by the pediatrician, all sorts of antibiotics. Ultimately, child was given when the AKT, even the uncommon antibiotics like clarithromycin. And such a child with the after 3 weeks developed now the joint pain. Probably third case was knowing that Dr. Chitkara is going to ask for the joint pain. So here the joint pain was there. Rheumatology started the naproxen and referred to us. This patient was from Rajkot for persistent high-grade fever, joint pain, and occasional vomiting and decreased appetite. More information, investigations before referring to us already done. Hemoglobin was fairly good, around 9 to 10. Total count, you can see that every time high with polymorphonuclear reaction. Platelets also, I will say not sky, but sky high. ESR was raised. Other investigations, tuberculosis point of view normal, negative. Vidal was negative. Renal functions, liver functions, CSF not showing anything positive. ASO titer negative. RA factor was done. ANA was negative. HI was negative. All cultures negative. Even urine for AFB somebody did was negative. Amylase was normal. Sickling test was negative. Brucellosis negative. Chest X-ray was normal. USG abdomen, mild altered texture of liver, increased echogenicity of kidney, thickening of jejunum and ileum, and enlarged mesenteric lymph nodes. If I provide more history, which we got later on, which was not revealed at Rajkot, that this child was having the multiple abscesses with cellulitis over chest at the age of 1.5 years. Now the child is 7 years. That means almost 6 years back, which required the hospitalization for 10 days, treated with IV antibiotics, 2 units of blood, AKT for 6 months. Even abscesses require INT. Tuberculosis history to grandfather, he had hemoptysis and he died 3 years back. I think with this information, what are your possibilities? Let Dr. Ramesh, you can start.
This history of multiple abscesses in the past and currently the child has presented with the infection, it is very much suggestive of some immunodeficiency. And till first slide, if you don't go to second slide, then it seems that there is some hidden infection. Probably it could be in the joint also, as the reports are suggestive of gross pyogenic infection. First 2 slides.
Okay, anything
The
else?
first two slides suggest that it is an FUO case because fever is there since last 20 days. And in the second slide, you find that there is increase of platelet count again and acute phase reactants. With multiple abscess, we should suspect probably a chronic infection, ongoing infection, and all the tests are negative. Can we have leptospira in mind?
Okay, leptospirosis. Or anything else from your side?
So the USG findings, please, once more.
Sorry?
USG findings, ultrasound findings, sir.
Okay. Sorry, USG abdomen, altered texture of liver, increased echogenicity of kidneys, thickening of jejunum and ileum, and enlarged mesenteric node.
So wide spectrum of possibilities here. Sir, tuberculosis is of course one of them. Lymphoproliferative disorders, malignancy, immunodeficiency, But the 1.5, typical specific history of abscesses at 1.5 years
Yes,
of
sir.
age,
Yes, sir.
that also opens up a possibility of what happened at that time, because blood transfusion also was given. So in infective endocarditis, we have certain presentations almost, though not very typical, but we have that.
Okay.
So whether that connects to these findings or not, that we'll have to connect.
Okay, so it remains one of the possible. Sir, anything from you beside these? That may be the tuberculosis, maybe the primary immunodeficiency disorder, maybe the leptospirosis, maybe the bacterial endocarditis, maybe the malignancies, anything else?
The only evidence in the history is entire family is suffering with tuberculosis.
Yeah.
So my decision will be disseminated tuberculosis.
Okay, disseminated tuberculosis. Now, fine. Now, if I go further, on examination, you can see the weight, height, I think not much affected, but febrile, tachycardia, blood pressure maintained, saturation maintained, pallor, no jaundice, cervical nephropias, as sir said, marked tachycardia but no murmur, liver 4 centimeters, spleen not palpable, and CNS was NAD. I think already point has been discussed. Investigations again, now the count is 66,400 and polymorphs 94. Platelets again almost 10 lakhs. ESR 140 and CRP more than 250, around 240. LDH raised. But sugar, renal functions, liver functions, electrolytes normal. Chest X-ray was normal. Even if I provide more information, USG on CT even was done, showed hepatosplenomegaly. Spleen now revealed the multiple splenic abscesses, possibly necrosis due to the lymphoma. These were the comment from radiology. Now, anything new or a very specific comment from any officer, please? Because now we have this finding. Even if I take one step further, can you think that what can be the causes for multiple splenic abscesses? Because now we have that very unusual, significant finding on CT.
That itself indicates splenic abscess indicates he had septicemia and he is suffering with bacterial plus added on some other deficiencies what he has.
Absolutely. So some deficiency and bacterial infection with the immunodeficiency. Yes, sir. Anything from you? Okay. Okay. So if I go further, just for information, whenever we come across the splenic abscesses, think for brucellosis. In sickle cell, it can occur. Falciparum following the infarction, yes, it can occur. Enteric is known somehow with the good drugs we don't come across. Bacterial endocarditis can cause, and even the plague, which is rare, but yes. Most of the investigations we did, not suggesting or not favoring for these things, and we went straight away for the echo. We showed the vegetations at mitral valve cusp and confirmed as one of our analysis said bacterial endocarditis, besides all other possibilities. But the point is, the chapter does not close over here. Blood culture showed this streptococcal pneumonia. I talked to the microbiologist that this is not the organism for the bacterial endocarditis. Now what will be your thought process?
The case has been investigated extensively, but the findings were never disclosed to us.
Findings like?
Because the basic thing is when somebody is having such a prolonged, we should do an echo. That's the basic first fundamental. If you hide that one, then it will be like this.
All of us know that after discussing any case, many times my postgraduates tell me, the lecture, sir, very nicely given in the Nelson. Very nicely given in the Nelson, but we'll have to search for that,
Yes,
sir.
sir.
It was known after some 3 to 4 or 6 weeks. Agreed.
Sir.
Any case of PO, the point is that a message, any PO, if you don't have the answer, go for the bone marrow, go for the CT abdomen, go for the echo, besides cultures and other things. I think absolutely, sir. But this wisdom came later on.
Re-emerging of previous incident.
No, sir, nothing was there. No sign.
No evidence was there.
Dr. Sham, believe me, not only myself, at least 2 other consultants were there. One pediatrician, I think he is sitting there. and it was not there at all. Even we didn't think for that murmur and everything, but we didn't get. Later on the echo was. Anyway, but I will take it further. Streptococcal is not the common organism. What is the answer from you? Yeah. Okay.
Spleen is present, sir.
So I think I am getting the
No,
opportunity to go further so that I can complete the case.
function.
Dr. Sham has said that multiple abscesses even in the past also. Why? Immunodeficiency disorder, multiple splenic abscesses, that's endocarditis, and therefore we went for the complement and multiple splenic abscess, and everything was due to the C3 deficiency. And C3 deficiency in this case was again discussed and confirmed by Dr. Mukesh Desai, and he said, yes, it is the whole story. Even the abscesses in the past was also because basically child is having the immunodeficiency. Of course, immunodeficiency, that if we say it's good, but you know there are 430 immunodeficiency disorders, we'll have to locate it. Now going for one more case. I think last but one, please give me the time. 15 years old maid. Started with fever, sore throat, cough for a week, better for somehow 10 days. Again high grade fever 100, 203, redness of eyes, body ache, that lasted for a few days. Low platelets were detected. In between, child was better for 15 days. Again the fever started, and I think this type of story is not uncommon. Now the fever again increased 100 to 103. Hospitalized under care of physician. Diagnosis enteric fever, treated with all the antibiotics which you can read from the screen. Later on, child there was a joint pain, swelling in elbow, wrist and knees were there. Readmitted under the care of physician. Diagnosis as reactive arthritis. I will run little bit fast. Treated again with the IV fluid, IV paracetamol, naproxen, hydroxychloroquine. Consulted by rheumatologist, diagnosed as, I could not understand what is the SPA, but some rheumatological condition, started the solumedrol, oral sulfasalazine, and symptomatic as well as supportive treatment. Later on again the steroid, developed now the skin rashes, diarrhea and high grade fever, which was considered due to some allergy, treated with some other drugs and antibiotics. When brought to us, fever 101 to 103, joint swelling, skin rashes, edema face, body ache was complained, and decreased oral intake, and probably I have these pictures also I will show you. Chickenpox just 7 years back at the age of 7 years. Asthma to mother, no contact or tuberculosis, some vaccines were given. On examination, temperature was there, febrile child, vitals normal, edema face, sclera was yellowish, maculopapular rash all over the body, cervical, axillary, inguinal, all lymph nodes enlarged, left hand is swollen, tender, other systemic examination non-contributory, liver just 1 centimeter, and spleen was not palpable. These were the pictures of the child, 15 years old boy. You can see the puffy face and even the generalized this type of the rashes all over the body. I think this information is sufficient. What will be the possibilities? Any of you, please. Sir.
Maculopapular rash with fever, scrub typhus should be number one.
Right.
But many questions can be raised about that involvement of the joints. First, why levofloxacin was started and whether this joint something can be.
I think all these things what started, I don't have the
Earlier,
answer
yeah.
because the previous people.
Well,
There
it's
are so
very
many
unusual.
questions that why they have started. Right, I know that they should not, but this is something already I got it.
But joint involvement after levofloxacin, IV levofloxacin.
But I
might-
think if I clarify, probably it is not due to drug. Consider that it is the disease process.
Okay.
That will help you.
Then the spectrum, I think should start with scrub typhus first.
Okay, scrub
investigate.
typhus number 1. Sir, anything else from you?
The amount of drugs he has received and the various diagnoses that were entertained by the physicians, it shows it's not a simple case first, and it has involved multiple systems. I would like to have the other investigations before I say anything.
Right.
Otherwise,
If you have
otherwise
something
I'll give you a
here.
DD. Sir, otherwise I'll give you a DD.
Yes, sir,
That is-
DD, we want the DD. We
It's
go
a,
for the final word. And I think any clinician has the final word. We are not going to discuss. We want to try to find out the final word. Of course, all the possibilities. So your possibilities, sir.
it's a connective tissue disorder
Right.
that has to be ruled out.
Yes.
Then
Can you name few connectivity disorder presenting in this way?
a rash, lymph node enlargement, plus joint pains, and 18 or 19, what was the age? 18.
15 years, 15.
15. So it should be a type of rheumatoid arthritis.
Okay. Any variety of juvenile arthritis. Okay. Yes, sir.
Pass.
Systemic onset juvenile idiopathic arthritis. Okay.
Monoarticular. And the fever has been since long standing. Patient was on multiple drugs. Probably my first on is Sogia.
Should I go
When
further?
some more investigations are there, we'll conclude it, sir.
Okay, sir. I'm afraid of my chairperson. If they ask me to stop, I'm afraid of it. I want to complete it. These were the investigations. Further, what we have done. And I think before referring to us, you can see the count almost normal. Differential not much helpful. PCV okay. MP was never seen. Platelets were, as I said, it's at low, but not the coming in the definition of the thrombocytopenia. Creatinine once was normal, SGPT normal, a refractor was negative. Again, lot many investigations, hemoglobin of course same, count now going the lower side, 2,700, 300, 500, 3,500. Differential you can see not much. ESR was not even raised. MP was negative. Platelets definitely every time low or even the thrombocytopenia. SGPT just every time mild enzymatic reaction. Even further investigation, urine multiple times didn't show anything. Investigations for dengue negative, typhoid IgM negative, uric acid was normal, chikungunya IgM was rapid test was negative, procalcitonin was not helping much. Even HLA-B27 was done by rheumatologist negative, RF factor negative, ANA negative, ferritin fortunately not raised, anti-SCV negative, TSH normal, Vidal negative, X-ray NET. Even more investigation before somebody asks me. PSG abdomen, first time normal, but on follow-up almost after a month, terminal ileum, mildly edematous, mesenteric nodes. And after again 1 month, mild long segment terminal ileitis with enlarged clustered mesenteric nodes, reactive lymph nodes, right lumbar region. Moderate splenomegaly, borderline hepatomegaly, the size they have given in the bracket, with reactive enlarged periportal lymph nodes. USG local parts, knees, 4 centimeter strip of fluid collection in pre-patellar space, extending into lateral aspect of right knee, mild synovial thickening was seen. 7 millimeter strip of the fluid collection in pre-patellar space, extending into lateral aspect of left knee, mild synovial thickening was seen. And I think many more information is with you, sir. Now, what is your
Sir, you
possibility?
have given so much information about the synovial thickening. Were there any rice bodies present there, sir? Anything, any other findings?
Nothing.
But it's not a chronic, that means we are not looking
At least there was no swelling clinical. Yes, pain was there.
Polyarthritis, ileum, intestine is involved, skin presentation was also there. It is definitely a connective tissue disorder.
Yes.
And if you want to classify, there may be 1001. I'm not interested.
So Dr. Ranganathan says that any variety of some connective tissue disorder. Yes.
Ophthalmic exam.
No, sir. Just routinely what I can see, that's all. Yes, sir.
CBNAT done or not done?
CBNet was not done.
Not done. If it has been done and negative, then I accept. Otherwise, disseminated tuberculosis is also a presentation.
Okay, so tuberculosis, one more next possibility. Anything else? Okay. Can you inform me the time? This was the later on somehow. First time it was negative. I don't know why it was done or not properly. But the PCR for the FMI virus was positive. And that was the case of infectious mononucleosis. Last case, and only I would say less than 2 to 3 minutes. Very short case.
Was it a coincidental finding of infectious mononucleosis?
That's a very good comment.
He has been sick for so many days. This can be a coincidental. It has no value as far as we are concerned.
Because he was on steroids for a long time.
But later on, for your information, if I tell you the follow-up, child was absolutely fine. For, I will say, more than 2 to 3, this patient was from Surat. Staying, actually, basically from Saurashtra, staying at Surat. And now even, after these many years also, child is coming to me, sir. It was 15 years, now almost 17, 18 years. And
Stopped
also-
all drugs.
But it is normal.
Sir, stopped all drugs and left the child to recover on its own.
Okay.
That should be the attitude.
I think this philosophy always keeps us happy. That whatever it is, right or wrong, understood or not understood, but the child recover. That's good. Yeah, I think that philosophy is good for us. Thank you very much. Now the last case. 5.5 years old male child, presented with high grade fever, vomiting, pain in abdomen, leg muscle pain. I think this is already very clear cut case. If I talk to you with even the investigations, it was dengue. The point which I want to discuss, and I will come to the focus point. Even the NS1 was positive, IgG, IgM was positive. Very uncomplicated, treated with simply with fluids, later on oral paracetamol, and almost child was absolutely fine. But after the 4 days, we are planning to discharge. After the 4 days, the child developed the, actually not persistent, but mild fever was there, and now the fever increased. But there was no vomiting, no pain in abdomen, urine was good, no erythema, but the child was now irritable, which was not at the time of the dengue. Vitals were normal, abdomen was soft, liver 2 centimeters, spleen not palpable, other systems on examination, no any positive finding was found. My question is, what could be the reasons for fever and irritability in Pakka diagnosed case of dengue even after the recovery?
Yes, sir. It seems that he was a clear-cut patient of dengue fever from which probably he has recovered. And now there is a inflammatory storm later on, which has given rise to fever and irritability. So dengue part is over, and in any viral infection, I would think rather suspect HLH first.
Okay,
Such
so
type
this
of
patient
situation.
is going for the complication like HLH. Now, is it so that HLH will go after the recovery or during the phase of the illness? Yeah. Here, therefore I said, here the patient recover. Even the, almost we are on the point to discharge. Mild
Can there
fever
be
was there,
coexisting?
and now it has increased.
Can there be coexisting infection?
Okay, that's very important point. Maybe some, because you know India, any infection can be there, and very common even.
Because
so that's very
dengue and
point.
rickettsia go together most
Yeah,
of
yeah,
the time.
anything. Sir, anything beyond that? That either the HLH, right, not convincing but still. Second point, sir said that search for the other associated infection with the dengue, yes. Beyond that, anything? Yes, sir, please.
Biphasic illness. The zone of the first part is a febrile part, viremic part. Second part is a febrile part. Third is a simple viral fever. That's immunological, not related to viremia. And during that time, during the recovery phase, they go in for a rash, particularly palmar and plantar rashes, in which child will be irritable.
So what points we got that either these HLH or some co-associated co-infection or even the immune some mechanism after the dengue is not allowing the child to go for the normal phase. Anything else? How many minutes may I know from the chairperson? Okay. Now I think already points it discuss the possibility that prolonged of immune mediated phase of the dengue. Sometimes they say that without any reason, just fever in the dengue reported on Indian pediatrics can remain even for weeks to months together. But the patient, if remains all right, please don't do anything. I will not speak anything what is written in the Indian pediatrics because we may go from the practice from tomorrow. Second, coexistent infection definitely, and even the local sometimes phlebitis or something which we should do it. Somehow secondary bacterial infection will come to our mind, but they say very nicely that the dengue somehow even in spite of the leukopenia, the secondary bacterial infection is not so common, unless kept in some complicated ICU or so. But in uncomplicated case kept probably in some general ward or so, in spite of on the low count. So I think that may not be the common. That is even the dictum from the standard textbooks. Now, again, on repeat investigation not helping much. As you said, other infections we ruled out. Urine was normal, culture no growth, X-ray was normal, USG abdomen mild hepatomegaly, no ascites, Mento test was negative. But what next already we have discussed. Now the child has developed these type of the pictures. After probably 5 to 7 days of the fever or so. And the point is, to save the time, now repeat CBC count is high, polymorphonuclear reaction, platelets raised, CRP raised, SGPT yes, SGOT raised, LDH. Albumin was low, and I'm sure that from this the thoughts are clear. USG abdomen showed hepatomegaly. USG neck showed the enlarged knee nodes. Anything else, sir? Comment. Yeah. Before I think organizer says stop, let me stop. It was Kawasaki, treated with immunoglobulin, patient recover. But this was not to our knowledge, and I opened the Indian Pediatrics. 2017, Dr. Piyush Gupta has reported that the Kawasaki is known to be triggered after this dengue fever. And he said there's so many patients of the dengue we see, but trigger for the Kawasaki is not so common that he reported, and dengue fever triggering Kawasaki is known. This is just want to share with you. Thank you very much, sir, for giving this opportunity. And I should thank all the 4 panelists for best, I will say, the way in which they, without any much information, how they analyze. I want now an important message, sir, from each one of the panel. You can give your opinion. I will say one important message for the audience.
Emerging, re-emerging, other diseases are being discussed, but coming back of the venereal diseases is observed already, and it has been highlighted by the WHO. So syphilis is going to be a continuous, what we have seen as students is going to come back. So also pertussis. So also other diseases which are going to come back due to this one. Plus the number of investigations that are being relied upon, ignoring the clinical science and clinical examination and your experience will lead all us up to that state.
So
thank you.
Emerging, re-emerging infections, common we'll have to keep in mind. And that very important that examination and history is more important than, yes sir, please important message. That is very short, but
So very difficult cases.
Clinical examination is hallmark what sir says. Fever for more than 8 days, thrombocytopenia less than 5 years, always suspect Kawasaki. What sir says now. We have seen 2 cases of Kawasaki in all the 5 cases. So suspect Kawasaki. If you are in a peripheral area, do a pro BNP. Don't forget.
In fact, all the cases are very interesting, but I'll give an anecdote. અમારી બેચમાં એક કલીગ હતો, દરરોજ એક સિન્ડ્રોમ નાસ્તો કરતા હોય કેન્ટીનમાં, દરરોજ એક સિન્ડ્રોમ લઈ આવે ને બધાની ખાંડે. પછી એને જયંત પટેલ સર told him that this time it seems that the gold medal is sure. I mean, it belongs to you if you pass. So full credit to Baldev sir for the atypical cases. Thank you, sir.
We respect the seniors because they taught us think about common disease first. Second point is uncommon presentation of common disease. Today, sir has misled us into that. And lastly, if you make a rare diagnosis, you are rarely correct. These were the things. Sir, age, sir, date of birth.
my birth date is on the record is wrong, but which is on the record is 1st June 1955.
He is senior, I am 56 born.
1 minute.
As per the date of birth, he is senior and I am junior. But probably the teaching of the same people is still remaining with us.
Thank you so much.